Okay, so ma'am, you will be sharing the CV and you will just introduce by yourself, right?
Yes.
Okay. So ma'am, without any further delay, should I start with the session for today?
Everybody has everybody joined?
So, greetings and a warm welcome to all the dignitaries present here. I am Swastika from Clarnit, serving as an allocation assistant to ensure a seamless experience. Clarnit is India's most trusted and widely used digital platform, offering a multitude of parenting services exclusively for doctors. Clarnit is elated to be chosen as digital partner for this event organized by CancerKids Strength of Smiles Doctors Network Maharashtra. So today's focus would be dealing with difficult variants. Let's begin today's session, for which I would like to invite Dr. Somdipa, who is a faculty in Pediatric Hematology Oncology, St. John's Medical College. Over to you, ma'am.
Good evening, everyone. I'm glad to moderate today's session. I am moderating today's session, and the panelists are Dr. Yamini Krishnan. She is my mentor and as well senior consultant in pediatric hematology oncology in St. John's Medical College. Dr. Kashif, consultant working as consultant in radiology in St. John's Medical College. Dr. Jainy ma'am, she is pediatrician as well, genetist, clinical genetist working in St. John Medical College as professor. And Dr. Meenakshi ma'am, working as pathologist, as a consultant in Rajiv Gandhi Cancer Institute. And Dr. Bibekanand Jindal sir, working as a professor in JIPMER. Welcome everybody. Now we can start our session for today, and we will take all the questions at the end of the discussion. Okay, we will share the slides. Most probably we cannot share. She has not stopped sharing. Can we share? Swastika, you have not stopped sharing. That's why we are not able to share
Ma'am,
more.
I have already stopped sharing.
Okay, one second.
So, क्या करानी? क्या solution?
She also can share. She might also. I have shared the slides in the Cancer Kid group. Can you please start sharing some
Uh,
technical issues are there?
Hello, ma'am. Hello.
Yes.
Ma'am, do you need assistance about the sharing?
I will share the slides. I will share the slides.
Okay, ma'am.
Okay.
चला यार follow करो. बस तुम कुछ वाजन. क्या follow शाखा.
Yes.
तुम्हें क्या लगता है बस? चला. क्या देखेंगे?
Dr. Somdipa, I think we can ask everyone to mute their uh, audios.
Yes.
Third stop हटो.
Swastika, can you mute everybody?
Third तो कब वाजन है?
Hello.
Can everybody mute, please?
मैं उसे क्यों वाजन है?
Yes. Thank
Can
you.
someone from
Yes. Can we? Can you please make a slide share mode? Okay, ma'am is sharing. Okay, ma'am. We can see now. Okay, she is Dr. Ravali, working as second year fellow in St. John's Medical College. First, she will present the case, then we will take questions one by one. Okay.
Good evening, everyone. So the first child that we'll be talking about today was a 1 year, 2 month old female child who presented to us with abdominal distension for 1 month as noticed by the mother. On examination of the child, she had abdominal distension, bilateral flanks were full, and bilateral masses were palpable. So we had gotten an imaging done. Initially, ultrasound abdomen showed features of bilateral nephroblastomatosis with a right mid-pole region lesion showing imaging characteristics suggestive of Wilms tumor. So on further imaging characterization by CECT abdomen, it showed bilateral nephroblastomatosis with right-sided Wilms tumor and with no metastatic lesions to the lung. Next slide, please. So these are the MRI CECT images that we had got initially. So MRI showed bulky kidneys with diffuse peripheral lobulated soft tissue nodules with relative hypo enhancement. So on the right side, you can see a well-defined lesion, which is a Wilms tumor, and on the left side, you see a diffuse enlargement of the kidney, which is suggestive of nephroblastomatosis. Next slide. And ultrasonography lesion appeared hyperechoic, which showed the renal vessels appeared normal. Next. So another important thing is if one of the nephrogenic rests has transformed to Wilms tumor, means that this can lead to transformation in other areas as well, which is seen in 2 areas as pointed by the arrows. Next slide. So this is post chemotherapy. There's an interval regression in the size of the lesion, which is seen on the right side, and you can see that there's always also been a decrease in the size of the nephrogenic rests, and there's a heterogeneous enhancement of the residual lesion. Next slide, please.
So my first question is to Dr. Kashif. What will be the radiological differentiation points between Wilms tumor and neuroblastoma, as well between Wilms tumor and nephroblastomatosis, and what is the role of imaging for staging of Wilms tumor?
Okay, so one by one we can address this. Can we go back to a previous slide? Yeah. So in this case, first let me clarify the difference between nephroblastomatosis and Wilms tumor. So here you are seeing bilaterally bulky kidneys on the left side of the screen. Kindly focus on the left side of the screen, which is pre-chemotherapy imaging. So in the left side of the screen, you have 2 images, one top and one bottom. The top image is a T2 weighted image and the bottom image is a contrast enhanced image. Usually these 2 sequences are enough to differentiate between the tumor and the nephrogenic rest. So as you can see in the nephrogenic rest or the nephroblastomatosis that is there, you can see that nodular little bit low signal intensity is there as compared to a tumor. Tumor you are seeing there appears little heterogeneous. Heterogeneous meaning it is composed of uh, different kind of signal intensities in the lesion. Homogeneous meaning it is appearing smooth and similar signal intensity. So if you can compare left kidney and right kidney, left kidney you can see lobulated peripheral T2 intermediate to low signal intensity nodules all throughout the renal parenchyma. And on the right side, one of those nodules has enlarged in size, is causing mass effect, is displacing the renal vessels and the hilum, is like a ball-shaped lesion and is having tiny cystic spaces on T2. And if you come down and see the lesion in the contrast enhanced images, you can see that left side, the whatever that was nodular part of the kidney is not showing any enhancement. But if you compare that dark area with the right kidney interpolar region, you are seeing some form of heterogeneous enhancement. So this is a very nice case to demonstrate the difference between the non-tumor nephroblastomatosis versus Wilms tumor in a nephroblastomatosis. So what happens is once one of the rest has transformed, there are chances that other rest might also transform. So that is also evidenced by one of the images on the left side of the screen. And post chemotherapy changes, what happens is the signal becomes darker. It's like a burnt out disease or like a post chemo changes. So you can see the thickness of that nodular lesion and the intensity of that nodular lesion on T2 has become reduced. It is now appearing as a thin, very thin rim. In the left side, you can see that thin rim, and right side, you can see the lesion has reduced in size. Also, the enhancement has slightly reduced, but is still persistent, meaning that there is a residual tumor. So this is how we can assess nephroblastoma, and MRI is the best modality, better than CT, better than ultrasound. MRI, non-radiation, and we get to characterize the different kinds of Wilms tumor easily, meaning the differentiation between nephrogenic rest versus Wilms tumor becomes more easy, although it is not part of widespread guidelines, but you can clearly see that MRI is so easy that anybody will be able to differentiate between a Wilms tumor and simple nephroblastoma. Coming to the difference between Wilms tumor and neuroblastomatosis, the thing is neuroblastoma, what happens is it's arising from adrenal glands, first thing. Or it can be extraadrenal, that is in the sympathetic chain and in the paraaortic region. Now, what happens is in Wilms tumor, we have to demonstrate the tumor arising from the kidney. So there is something called as a claw sign, which you can easily Google, or I think in this one of these images, in the sagittal images, which you can see, you may not be able to appreciate the claw, but you can see that it is surrounded by parenchyma on almost all the sides, and in all the planes you are seeing that, which means the lesion is most likely to be arising from the kidney itself.
Excuse
Suppose if
me,
the
you want
lesion
me to point here? You want me to
Yes, yes,
point
yes,
somewhere?
yes, yes, yes. That area is fine, ma'am. So that ring of parenchyma is surrounding the lesion, which means the lesion is arising from the kidney itself. Now, what happens if lesion is above the kidney? In this example, I will try to say you think of it as normal case with liver. So you can see the liver in this left side of the image. Suppose if there was a lesion there, it would also displace the kidney inferiorly. Instead of that subdiaphragmatic liver portion, if there is a tumor arising from adrenal gland, that will also displace the kidney. That is the most important point to differentiate neuroblastoma from nephroblastoma or Wilms. Apart from that, we have other features such as the migration of tumor along the course of vessels. So the tumor in neuroblastoma, what happens is it will go along the course of vessels. So it will be going very diffusely and encasing, easily crossing the midline, and then going to the left side, encasing all the major abdominal vessels such as aorta. It may even lift the aorta, and then it may encase the IVC. So this pattern occurs. But what does Wilms tumor do? Wilms tumor enters the vessel from inside of kidney and goes into the renal vein. And then from the renal vein, it goes to IVC. Once it has reached IVC, it can go above towards the heart and to the left side also. So apart from Wilms tumor, what else can go like this? A clear cell sarcoma. So these two tumors have vascular invasion, and neuroblastoma has vascular encasement. This is another important differential finding. Apart from this, we use something called as calcification. Calcification is rare in Wilms tumor, common in neuroblastoma, but doesn't mean cannot be seen in any of them or not be seen in any of them. Most important is the epicenter of the lesion. If the epicenter of the lesion is suprarenal and it is displacing all the structures such as liver, such as kidney, then and the diaphragm, then you will see the mass in the like the subdiaphragmatic region. But if the lesion is suppose from the upper pole of kidney, That is when we will have the doubt between Wilms tumor and suprarenal mass, that is a neuroblastoma. So what happens in suprarenal masses is that time you have to demonstrate the claw sign. If something is arising from the kidney and has an exophytic component, will be at least surrounded 180 degree or 270 degree by a renal parenchyma. So you have to search for that clawing. So that I'm sure if you search online, you'll easily find it. But most of the times, with experience, you will also rule it out based on clinical picture. So clinical picture also may be slightly different, and it may not be as palatable as a Wilms tumor. So that is one thing. And most of the times, imaging is going to differentiate it more than 95% of the times. Then I think one more question was there. What was it?
Staging, a role of imaging in staging of Wilms tumor.
Staging. So, first thing what we have to do is rule out first whether there is a tumor in left side or not. So, what we usually do is first we see whether left side kidney is having a lesion or not. Because if it is bilateral Wilms, then it becomes directly stage 5. So, first that we see. Suppose that is not there, then we see whether there is any metastasis in the lung or liver or lymph node. Once that is also not there, then most of the staging is based on the after operation. Another thing which we see is perilesional fluid, like subcapsular or extracapsular spread or exophytic component. So our staging imaging wise goes retrospectively, like ulta. So if there is a bilateral lesion, it is stage 2, sorry, stage 5. If it is having any lung mets, liver mets without any bilateral lesion, then it is stage 4. Then 1, 2, 3 depends also on the resected specimen whether any disease is left behind. So that predictors, imaging predictors are if the lesion is in the vessel or if there are bulky nodes which are difficult to remove. So even if there are nodes and they are completely removed and margins are negative, then the stage is better. So if the stage is, if there is any extracapsular spread of the lesion, then it is considered stage 3. Stage 1 and 2 can vary based on the surgical management.
Okay. Thank you, Dr. Kashif. Can I see the next slide, ma'am?
Nephroblastomatosis usually does not have calcification, sir. It will usually be homogeneous, and calcification, if present, we have to rule out again Wilms tumor transformation, because Wilms tumor is more commonly going to have calcification.
Okay. Now I would like to ask Jainy ma'am, what will that the syndromic association of nephrogenic rest and Wilms tumor? Jainy ma'am.
Yeah. Good evening to all. So coming to syndromic association for Wilms tumor, uh, if you look at all the Wilms tumor, I think 10 to 15% of them can have a genetic basis. And there are some clinical features which you look for to see if there are any predisposing factors for Wilms tumor, genetic predisposition. One will be like bilateral Wilms tumor, and whether if it even if it's unilateral, if there are multicentric foci seen, then again there is a chance that there could be a genetic cause. Early onset disease, like less than 2 years of age, and predisposing syndromes. So if there is a syndromic association, when we come to that, um, there are specific clinical features we should look for in a child with Wilms tumor. So most important will be, as most of you would have seen, look for hemihypertrophy or hemihyperplasia to see any discrepancy in the size of the limbs or the length of the limbs. That is one thing where you will go into evaluation for Beckwith treatment related syndromes. Then, if there is no hemihypertrophy, and then look for features like in the eye, look for aniridia. So, WAGR syndrome or aniridia related PAX6 gene related aniridia, Wilms tumor relation is established. So then there are some features you look for genitourinary involvement, I mean anomalies in children. where if a male can have under masculinized genitalia, so the WT1 gene has these features, Wilms tumor, with these genitourinary abnormalities. And so detailed eye examination, detailed genitourinary examination, and other syndromic features should be looked for to classify them into any known particular syndrome association. I think vector treatment we will deal again later. So even sometimes there are some, I think 1 to 2% of children may have a family history of Wilms tumor, like another relative affected with Wilms tumor when they were childhood. Even in them, the genetic cause may be known only in maybe 1/3 of the cases. 2/3 of the cases, still you may not get a genetic cause because it may be unknown or we have not yet picked up the cause for those. Though if it's in family history, we'll definitely think there could be a genetic cause, but only in 1/3 we may find a case. So depending on the clinical features you are seeing in the child, you may have to decide on what testing to be done. So it could be microarray, then it could be whole exome sequencing, or it could be testing for Beckwith-Wiedemann, like methylation testing you will have to do. This is how we approach a child with Wilms tumor.
Yes, thank you, ma'am. Now, my question is to Yamini, ma'am. Because this child has Wilms tumor one side and other kidney has nephroblastomatosis, so what will be the treatment strategy for this kid?
So there are a couple of treatment principles that we have to keep in mind when we are treating a child with Wilms tumor with nephroblastomatosis. So, of course, neoadjuvant chemotherapy is the standard of care because your aim would be to achieve a nephron sparing surgery. Because at any point of time, there's a chance that the opposite kidney can develop a Wilms tumor, and the opposite kidney can also might also need a nephron sparing surgery. So any Wilms tumor, you have to give neoadjuvant chemotherapy as to give enough downsizement so that NSS can be achieved. The other advantage of a neoadjuvant chemotherapy is that it is also the treatment for the nephroblastomatosis. The second principle to be kept in mind is that always when treating a child with nephroblastomatosis, look out for Wilms tumor. We have seen, Wilms tumor occurring during treatment at the complete nephroblastomatosis lesions. The third, as Dr. Kashif said, always in imaging, either in the interim analysis or at the completion of treatment, if you see these lesions that are progressing or these nephroblastomatosis areas that are getting rounded, or if you find heterogeneous lesions within the heterogeneous like lesions within the nephroblastomatosis areas, always think of Wilms tumor. And the third principle that you have to keep in mind is that after completion of Wilms tumor treatment, you have to give a year of maintenance for the nephroblastomatosis. That will last for a year. And this has been actually, most of us follow the PSYOP-9 protocol, and the treatment goes on for a year. So the next question is, what chemotherapy to be given? So the umbrella protocol or the RTSG protocol, which is based on the PSYOP backbone, shows that VCR actomycin D is the treatment of choice in these situations. So you give for 6 weeks, and then you reassess whether the child can go in for a nephron sparing surgery. If not, you have to give another 6 weeks of the same treatment of VCR and actomycin D, which is given weekly. So once you reach 12 weeks, as in all solid tumors, beyond 3 months of the same treatment hardly gives you any result. So if you're not able to achieve an NSS by the same regimen by around 12 weeks, you have to think of changing the regimen. an umbrella protocol actually advises us to change the protocol to the high risk protocol of the cytopalm. So the high risk protocol is an intense protocol which has drugs like cyclophosphamide, adriamycin, carboplatin, and etoposide. It's an intense regimen, in which again you can give for 6 weeks, try to reassess and achieve NSS. So this would be probably some of the principles that are involved in the treatment of Wilms tumor with nephroblastomatosis.
Thank you, ma'am. Can I see the next slide, please? My question to Meenakshi ma'am, what are the pathological features to differentiate between Wilms tumor and nephroblastomatosis?
Hi, good evening, everyone. So, when we are seeing a Wilms tumor, we are talking about large resection specimens because we don't usually get biopsies for nephroblastomatosis. We get a triphasic picture in Wilms tumor. It's epithelial component, mesenchymal component, the stromal one, and the blastemal component. So that becomes straightforward. But when we are seeing a nephrogenic rest, the tubule, it also looks like small tubules. It looks like glomeruli. So the click there is if you see a demarcation, and especially if we have a perilobar location, it really helps to call it a nephrogenic rest. If there is a clear demarcation with the rest of renal parenchyma, they are small, the cell size is very small, and there is usually not much mitosis in it as compared to the blastemal component that we see in the Wilms tumor. So that helps to differentiate. But sometimes if the size of the nephrogenic rest is large, so then it becomes tricky. So usually the tumor will have some capsule or a pseudo capsule if it's a small size. If it's a big size tumor, then it becomes easy to differentiate. And when you have intralobar nephrogenic rest, then also you will see some intermingling with the normal glomeruli and tubules of those nephrogenic rests. So it will differentiate it from a Wilms tumor. So that is on the morphology.
Okay, thank you, ma'am. My question to Bibekanand sir, that in which conditions we can consider upfront nephrectomy, and for this kid, because this kid has one Wilms tumor, other kid nephroblastomatosis. So as Yamini ma'am told that the child will require nephron sparing surgery. So what will be the surgical principles for this kid?
Am I audible?
Yes, sir.
As we know, I think the Wilms tumor protocols differ. There are two group of thoughts. One is COG protocol and one is SIO protocols. And COG protocols completely believe from the upfront surgery. So whenever a tumor comes, if imaging wise it is resectable, it's not encasing any major structures. It's the upfront surgery basically. In the SIO protocols, most of the tumors we go for a upfront chemotherapy. Except in that cases also there is some exceptions, like when the children is less than 6 months old, or when there is a bilateral Wilms tumor, bilateral renal lesions are there, or there is a unilateral single kidney with a tumor is there, or any syndromic patients, which is a likely propensity to develop a metraconus Wilms tumor high likely, or a Wilms tumor with a IBC thrombus, which is encasing any going beyond the hepatic vein. In that cases, we try to reduce the thrombus size or do the nephron sparing surgery in bilateral Wilms tumor.
Okay,
Upfront
sir.
chemotherapy. So, and regarding the surgical principle for this kid, uh, like there is no doubt, as madam has told, we have to preserve the kidney as much as possible. So we have to give a chemotherapy 6 weeks first, when Krishnan actinomycin, reassess if there is a response is good and NSS is possible, do the NSS at the 6 weeks one side, and then further do the other 6 weeks chemotherapy. By the time you get some gap also, and do the nephron sparing surgery on the other side. If the 6 weeks assessment is not, let's say you see that partial response is there, you can give further 6 weeks of chemotherapy, and you can reassess for your surgery. And it can be done at the same setting also, and it can be done in two settings, 2 weeks intervals. This bilateral nephron sparing surgeries.
Okay, sir. So my question to Yamini ma'am, that sir has told that what are the indications of Bibekanand sir has told what are the indications of upfront nephrectomy, but in some situations we can consider for biopsy in Wilms tumor. So does it upstage the staging of the Wilms tumor?
So there are some indications for biopsy in Wilms tumor. So these are when you're thinking of alternate pathologies. So when are these situations? One, if you have a child that is more than 5 to 6 years, you have to actually think of an alternate pathology. The second is when the child presents in with abnormal presentations, like you have a mass, you have a severe urinary tract infection, you have the child coming with septicemia with a renal mass, when you have psoas extension, because all these suggest an alternate pathology. When you have a unusual actually radiological findings, like Dr. Kashif said, extensive calcification, which is very unusual in a Wilms tumor. The other is when you have bulky lymph nodes. Lymph nodes are not very common, means you when you see by imaging, you don't see huge lymph nodes, bulky lymph nodes in Wilms tumor. A younger child, probably less than 2 years, presenting with extensive lung metastasis, then you have to think of a RTK, a rhabdoid tumor. When you have, extra pulmonary as well as extra hepatic metastasis, like bone seeking tumors, no, bone, brain, all these, you have to think of clear cell sarcoma. So radiological features are very important. And if you have these abnormal things, think of alternate pathology and might be an indication for biopsy. The other is when you have biochemistry findings of hypercalcemia. This is very unusual in Wilms tumor, one of the indications for a biopsy. The other is when you have a very high LDH. LDH values, though are elevated in neuroblastoma, are hardly elevated in Wilms tumor. So if you have a very high LDH value, this is also one indication for a biopsy. So whether it upstages the tumor, with the recent techniques available, like better cutting needles, the retroperitoneal guided approach, because most of the time now we do CT guided retroperitoneal approach for biopsies, the chance of complications associated with the biopsy is very less. If you see the literature, it's around 1.6 percentage risk of bleeding or tract recurrences, or and one study actually has said a tract recurrence rate of around 0.5 percentage. So but the issue is, there's a large study from UK which has shown that in a child less than 10 years, a biopsy might not actually give you a real advantage in a Wilms tumor. So if you have these abnormal findings in which you are thinking of an alternate pathology, there is an indication for a biopsy. But for a routine Wilms tumor, the yield out of taking a biopsy might not be very much. There's not much, according to the UK study, a change in the pathology. So I think it's a safe procedure, especially when you're thinking of alternate pathologies, sarcoma, because the regimens that you would be using would be an aggressive regimen rather than that used in a Wilms tumor.
Yes, ma'am.
Just want to just put a comment here. Okay, when we are doing a open biopsy, it does only upstage the tumor. When you are doing a ultrasound guided biopsy from a retroperitoneal space, like posteriorly, where it goes does not cross the transperitoneum, it does not upstage the tumor.
Yes, sir.
Yes, sir. Next slide, please, ma'am. So to summarize this case, now we know that radiologically how we can differentiate between neuroblastoma and nephroblastomatosis and Wilms tumor. So there are only few indications where biopsy is actually required. Otherwise, we can treat the malignancy with chemotherapy and response assessment, and then we can further process surgery or further chemo is required or not. So as ma'am has already told, as per SIOP 9, or umbrella protocol with the background of SIOP. They need 6 cycles of 2 drugs chemotherapy followed by reassessment, and then again 6 drugs if required, if surgery is not possible, or the change of plan of chemotherapy if the response is not sufficient. And definitely for nephroblastomatosis, after completion of treatment of Wilms tumor, we need to continue treatment monthly with 2 drug regimen at least for 1 year, and they need regular follow-up to for clinical examination, and also syndromic association should be ruled out to prevent the chance of development of Wilms tumor of the opposite kidney. Next slide, please. So this child has received 6 weeks of chemotherapy, and we with vincristine actinomycin, and after that we have reassessed, and the MRI has shown there is significant reduction of the size of the malignancy. So we are planning for surgical intervention for this kid. And also we have sent genetic evaluation for this kid because the child has nephroblastomatosis, and this has found BRCA2 autosomal dominant heterozygous mutation. After literature review, we have seen that BRCA2, if associated only with FANC, then there is increased chance of malignancy. Anyway, the child will be under follow-up with us after completion of chemotherapy. So we can go ahead with the next case.
Okay, so coming to the next child, we had a 1 year, 2 month old female child who presented with a history of incidentally detected abdominal mass and hypertension in an outside center. So the imaging done outside showed initial ultrasound showed a large heterogeneous retroperitoneal mass with encasement of the aorta and IVC and infiltration of both kidneys with mild hydronephrosis. So further CT scan was done on the same child, which showed enlarged bilateral enlarged kidneys. In the right kidney, you had a mass of about 7 into 6 into 5 centimeters arising from the lateral aspect of the kidney in the upper, mid, and lower poles. And in the left kidney, you had a 7 into 5.6 into 5.3 centimeter size mass arising from the lower and interpolar regions of the kidney. And the normal renal parenchyma was found to be displaced. Next slide, please. So, child was diagnosed as Wilms tumor outside and received neoadjuvant chemotherapy with VAD chemotherapy for 12 weeks. And repeat imaging, which was done outside, showed no apparent interval regression in the size after 7 weeks of chemotherapy, following which they decided to give 5 more weeks of chemotherapy and was referred to our center for further management as they felt like there was no regression in the size of the mass. So at our center, repeat imaging was done, and we even held an MDT discussion. So ultrasound imaging at our center also showed bilateral enlarged kidneys with heterogeneous cystic lesions, and CT showed heterogeneously enhancing solid cystic lesions in both kidneys. Same imaging findings suggestive stage 5 Wilms tumor, and CT chest showed no evidence of metastasis. Next slide, please. So this is the imaging finding. Plain and contrast enhanced CT images were done showing bilateral renal solid cystic masses with a fat component of the right renal mass, and filling defect was noted in the bilateral renal pelvis, which is suggestive of tumor extension. Next slide. And
Okay, you wanted to.
that's fine. Okay, previous slide, please. Sorry. So this is just the imaging which was done. The above image, which is shown on the right side, is pre-chemotherapy, and the below image, where the green arrow is pointing, is post-chemotherapy. Although it doesn't apparently look like there's a change in the size of the tumor, you can see some necrotic changes in the mass, which Dr. Kashif will help us describe better. But this is suggestive that chemotherapy, there are post-chemotherapy changes, suggestive that the tumor did respond to the chemotherapy that was given outside. Next slide, please.
So my question to Yamini ma'am, because this child has bilateral Wilms tumor, what should be the chemotherapy and radiotherapy principles for this kid?
So a bilateral Wilms tumor actually is better treated at a specialized center which has experience with NSS. So that's the main principle. If you don't have experience with NSS, it's better that you don't treat the child, because this is a very very complicated situation. Bilateral Wilms is always complicated. So as Dr. Jindal said, that PSYOP has always neoadjuvant chemotherapy, and NWTS, recommends direct surgery. So this is one situation in which both the, study groups actually recommend neoadjuvant chemotherapy. And most, study groups recommend an evaluation at 6 weeks to see whether NSS is possible. The next evaluation again would be at 12 weeks, like we discussed in the older, the previous patient, with an aim of bilateral NSS. What drugs to use? So PSYOP recommends 2 drugs with VCR and actinomycin D, while NWTS, if you're using the NWTS type of protocol, you use 3 drugs with VCR, actinomycin D, and adriamycin. Recently, the AREN protocol 0534 of the COG actually has been completed, and it has shown that a biopsy at probably 6 weeks, if you are not undergoing a NSS at 6 weeks, that is, the patient is not fit for an NSS at 6 weeks, because that's when your first evaluation is there. It's always better you take a biopsy and see whether the child has any other high risk pathology, and so that you can intensify your treatment. So it's the first time probably there's a recommendation on bilateral WIMS that the evaluation should be at 6 weeks, and actually a indication for biopsy, so that you can use a aggressive regimen early in the protocol, especially when you have the unfavorable histology. You can use the UH1 protocol as per NWTS, or if you have the LOH, if you do, genetic studies and you find LOH, you can actually give an aggressive protocol, which might benefit the child, and the child might go for NSS at a early stage. You need not, wait for another 12 weeks of giving the same protocol. What about, the use of radiotherapy? Of course, NSS is always, recommended, but many of the time, some patients actually have to go for a bilateral nephrectomy, and, you'll have to think of, giving a renal support and then transplant after 2 years. There are some situations you can do a unilateral nephrectomy. Opposite side, you can do a partial nephrectomy and, a partial resection of the tuber, and rest of the tumor you can give radiotherapy. So that is sometimes radiotherapy is used in such a situation. The other situation is when you have pathological report of stage 3. So stage 3 after NSS, you have to give radiotherapy. What about adjuvant chemotherapy? So adjuvant chemotherapy in bilateral WIMS actually is decided by the stage of the tumor as well as the highest grade, or what is the pathology. So if you have blastomal element, you have to use a high risk pathology. If you have diffuse anaplasia, you use again the high risk, the aggressive protocol rather than your usual protocol. So these are probably some of the principles involved in bilateral Wilms tumor. I have not covered on the, the surgical part. Probably Dr. Jindal can, enlighten us on the surgical part of the, bilateral Wilms.
Yes, so
Yeah,
the next question.
I think definitely there is a role of surgery after the chemotherapy. And the way, because the bilateral Wilms tumor and there is likely development of renal dysfunctions post chemotherapy and post surgery, we need to preserve as much as kidney as possible. And that's why we give a 12 weeks extended chemotherapy. And if it is not responding, we give another refractory mode of chemotherapy like vincristine and etoposide. Sorry, etoposide and cyclophosphamide and other things. So the various principles here, like for the nephron sparing surgery, people some can do enucleations or the tumorectomy, and sometimes they do a partial nephrectomy, depending upon the as much as tumor we can safely salvageable, as much as kidney can be preserved. And most of the times we do in a single setting if the tumor is in the unipolar locations. However, if that we see that there is a risk of impairment of the kidney functions, we do in stage settings where we do the less involved kidney. Some people do the less involved kidneys and then do the more involved kidney, so that we are safe on one side. One kidney is function is preserved. Then we can go on the other kidney and preserve the other, try to salvage the other kidney also. So that is the most followed principle in the case of bilateral Wilms tumor.
Yes, sir. So next question almost is covered already. Treatment options for Wilms tumor not responding to protocol.
Yeah.
Ma'am has already covered already. That after 6 weeks we have to reassess that response is there or not. Or the good point is made that we have to plan biopsy that point of time, that we need to give higher risk, higher, we have to expose to carbodoxo etoposide cyclophosphamide regimen, or we can again go ahead with the 6 weeks of again the same chemotherapy. And if we go ahead with the 6 weeks of again chemotherapy, then we have to plan for surgery, or we have to upfront that point of time itself.
Alternate diagnosis also has to be considered if chemotherapy response is not there.
Yes, yes.
That madam has told, I think.
Okay, next slide please, ma'am. So this is the same as per umbrella protocol. This is the protocol when refractory disease. So they receive cyclophosphamide, doxorubicin, carboplatin, and etoposide that we have already discussed. Okay, next slide, ma'am. So as per discussion in our MDT, we decided the child already received 12 weeks of chemotherapy, and then MDT discussion, there was already tumor size was same, but definitely there was some necrosis. So we planned for surgery, and the child underwent left radical nephrectomy along with CAPD catheter insertion for peritoneal dialysis or hemodialysis if required. And one baseline DMSA also we have done before doing the surgery. And subsequently, the child underwent right kidney nephron sparing surgery. Luckily, the child improved and didn't require any dialysis. And ultimately, the child was treated as intermediate risk protocol as per the histology. Next slide, please, ma'am. Yes.
Okay. Now coming to the third child, we have a 2-year-old female child who presented with complaints of fever for 1 month and abdominal distension for 10 days. So outside, they had evaluated the child and found the child was found to have a right, well-defined heterogeneous enhancing soft tissue lesion about 9 into 7 centimeters. The mass was crossing the midline, abutting the inferior surface of the liver, the abdominal wall, bowel loops, displacing the pancreas, and it was encasing the right renal artery. So one of the main features was a filling defect was noted in the IVC at the infrarenal region, extending up to the infrahepatic region, suggestive of a thrombus. There was also ill-defined soft tissue thickening, which was noted in the paracaval and aortocaval region, probably metastatic in origin. And child post-imaging, child received 4 weeks of VA chemotherapy. Next slide, please. Next slide.
It's not working.
Yeah.
Next slide, ma'am. Monica, ma'am, next slide.
I think slide is not moving. Can you reshare the slide?
Uh,
This is someone else's sharing, no?
ma'am is resharing.
I'm sorry, I lost signal in between. Should I stop sharing?
I think someone else is
Case
sharing.
3. Yes, yes.
Okay.
Okay, I'll stop sharing.
Okay, thank you. So post chemo imaging showed a large heterogeneously enhancing soft tissue exophytic mass rising from the mid and lower pole of the right kidney abutting the inferior surface of the liver, and it was encasing the pelvic ileal system, renal artery, and the vein. And the same filling defect was noted in the right renal vein extending up to the infrahepatic IVC, suggestive of the tumor thrombus. Child was referred to us for further treatment, and at our center, repeat CT, the CT chest was reviewed, and it was discussed in MDT. Tumor size was about the same, and that IVC thrombus was persistent. Next slide, please. So these are the imaging findings. Um, so the initial image on the which is seen on the top is before initiation of chemotherapy, which shows the renal mass extending into the right renal vein, IVC, and the contralateral renal vein. And post chemotherapy, you will see that there's a decrease in the size and enhancement of the mass and the tumor thrombus, as shown by the green arrow. If you can see, suggesting partial response. The filling defect, however, it was persistent, suggesting there's some amount of intraluminal component as well. Next slide, please.
So to discuss, what are the radiological features of tumor thrombus in Wilms tumor, and is ultrasound Doppler is required for all the cases for Wilms tumor, or CT abdomen contrast is sufficient for that?
Um, this is like actually most of the times CT will be sufficient. We will be able to see. Where I think ultrasound might be helpful is if it is like we want to know whether IVC is patent or not. Like obviously we know that there is a thrombus, but IVC patency, like whether it is partial thrombus or complete, it may help. But I think 95 or more than 95% we will be able to see nowadays with CT, unless the CT scan performed has not been done in a proper phase. Like meaning, so usually we have to perform the contrast enhanced CT around 50 to 60 seconds after injection of contrast. If the imaging done is not done at the correct timing or is of a poor quality, then it is better to assess because if you don't want to repeat a CT, you can easily assess with ultrasound. Pitfall is that if child has lot of bowel gas shadows, you may not be able to trace the entire renal vein and IVC. For that, bowel preparation will be required. Retroperitoneal approach can also be done and may be possible, especially if the patient is lean. And what are the features? Features are that usually the vessel will be anechoic or like hypoechoic, where we can see the blood flowing. And if that is not seen, meaning if something else is seen, isoechoic or hyperechoic lesion, which is filling the vessel, and we put the color and we are not seeing flow, that it means there is a tumor thrombus. Usually, we will be able to trace this from the lesion into the renal vein, and usually we will be able to trace it into the IVC as well. Now, in post chemotherapy, what happens is the CT may show absence of enhancement of the tumor, meaning the tumor thrombosis. What has happened is tumor would have gone to the IVC and then blocked the blood. So, apart from tumor, it will also have the clot component to it. So, what will happen is the tumor would have responded, meaning the tumor thrombus enhancement will be not there, but then this clot component will still be there and it may not resolve completely. In these cases, ultrasound will be useful to know how much of IVC is recanalized and whether there is bland thrombus or a tumor thrombus. Sometimes it can detect. Sometimes if there is a doubt, usually like PET-CT can also help in detection whether there is the uptake in the tumor thrombus. So this is an upcoming role in PET-CT. So I think I have answered. Do you have any other questions?
No, that's it. Sir, what will be the surgical principles for tumor thrombus management?
There is, in this case, particularly when the thrombus is extending to the right atrium and even if it's going to the below the renal vein and to the common iliac vein, especially when it is going to the right atrium, you need to do the surgery under a cardiopulmonary bypass. and you need to control the IVC and do a carbotomy. And in case there is a venous involvement also there, we need to do some PTFE graft also, or maybe a venous graft from the IJB or somewhere. And however, if the tumor, somehow I am really confused with the pre-op CT and post-chemo CT, pre-chemo and post-chemo. In the pre-chemo CT images, the thrombus is saying it is extending below the infrahepatic. Infrahepatic means I presume the thrombus is below the where the hepatic vein joins the IVC.
That we can show the
can we go
images.
previous slide, please?
Dr. Kashif, can you please explain the tumor thrombus?
Yeah, so the thing is, there in the cranial most part where IVC is opening into the atrium in the pre-chemo, that is shown as a green arrow, there is an artifact there, but the tumor thrombus has stopped actually. It has not gone fully into the right atrium, or it is at that cavoatrial junction. And below we are seeing the green arrow where the right atrium is not having any filling defect. The tumor has stopped there. So basically what would have happened is, due to breathing motion, it may have interpreted as a tumor going into right atrium also. So this easily can be differentiated on echocardiography also. And
Yeah,
I think in this case, it may not have gone fully into the heart. It may have been at the cavoatrial junction, and post chemo the clot would have little bit retracted, and then we are seeing the enhancement has reduced, the bulkiness of the tumor has reduced. And as far as iliac component is considered, I don't think what has happened is tumor has gone to the left renal vein, and also little bit in the infrarenal IVC, but it did not go completely into the iliac vessels. So iliac vessels are actually patent. If in the above image also right iliac vein is seen, I guess left is not seen. But anyways, in this case, it has gone just to the from the right renal vein to the IVC, then to the left renal vein, and cranially it has gone into the infra, up to the cavoatrial junction, the hepatic IVC, and then that has retracted, enhancement has reduced, but bland thrombus, like the due to clot, that is present. So chronic thrombosis is still present.
yeah, and there is no doubt the tumor is there in the atrium or not clearly shown. In that case, transesophageal echocardiography is more a better options to do the whether the thrombus is extended to the right atrium. We have done not in the case of Wilms tumor, one in the hepatoblastoma where it was extending to the right atrium we had thought of, but it was like when each tumor was popping into the right atrium basically, tumor
Yeah,
thrombus.
General boss, can I speak? Dr. Basant here.
Ah, boss.
Yeah, I am sharing this. Actually, recently we have operated a child with Wilms tumor on that is the same scenario is here. There was a huge tumor on left side and extending up to this junction. Just entered the right atrium and it's going in infra renal part of IVCs and opposite side of renal vein. So when we operated, what I think if tumor is above the junction of hepatic vein with IVC, we must go for cardiac bypass. We went, phlebotomy was done, all tumor along with IV subthrombus was removed, and tumor was infiltrating the wall in some places that was removed with tumor, and pericardial patch was
The tumor
taken
was
and
infiltrated. What?
hello,
Uh,
infiltrating the wall of IVC
okay,
tumor.
sir.
Yeah.
Yes, sir. Yes, sir.
So that one or two places it was excised with that tumor, and that pericardial patch was taken, and whole IVC was repaired. Intraoperatively, it was there was a good flow of blood, but within 15 or 16 days, there was again a thrombus in the IVC, and we thought it is a tumor thrombus. We went for as our radiologist said. PET is the best modality to look for it is a tumor or it is a simple clot. So that was a simple clot, and it occurs because long-standing thrombus of IVCs gives a lot of collaterals. So most of the blood goes through that collaterals, and empty IVC, either which we repaired, that has tendency to clot again. Sorry. Thank you.
Yeah,
Thank you, sir.
in these cases, normally we need to keep in the control that we need to keep control of the other renal vein also. First control, suprahepatic we need to keep a control, and the infrarenal also we need to keep a control and do a carbotomy. And where if there is a venous involvement is there, then you need to do a remove that part of the vein and repair it either with a pericardial patch or a PTFE graft patch, or maybe an internal jugular vein patch also. So the idea is to keep a control of the other renal vein so that the tumor thrombus does not migrate also. Thank you.
Okay, sir. Ca- Can I see the next slide? Yeah, thank you, sir. So, question to Yamini ma'am, that any treatment modifications would require for tumor thrombus or any role of anticoagulant for tumor thrombus?
Just a minute here. The role of anticoagulant post PTFA. Suppose you are doing a venous graft
Bypass.
in
Okay.
that, like some PTFE graft or a pericardial patch you are using. In that cases, we use the anticoagulant for 3 months to 6 months extended period of time so that prevent any thrombus. So we have 2 or 3 cases were done where we have to keep a extended anticoagulation so that the tumor thrombus does not form, or that any not a tumor thrombus, or any thrombus will not form basically. I worked regarding the chemotherapy. If it, the venous involvement is there, it upstages the tumor, so it becomes stage 3. Accordingly, then chemotherapy needs to be changed.
Yes, sir. And to Meenakshi ma'am, importance of pathological staging and what is the difference in pathological staging between PSYOP versus COG?
Yes. So we all know that pathological staging is one of the most important prognostic factor in this Wilms tumor. So the COG and SIP, they don't have many much differences. Most important is that COG, the Children's Oncology Group, they say they use staging when it's a pre-chemo before surgery, the pre-chemo surgery has been done. But SIOP staging is used for post-chemo specimens that we get. We are mostly getting post-chemo specimens. So basically, stage 1 and stage 2, both these systems, it's a complete dissection. All margins will be free. So in stage 1, there is usually no sinus fat invasion in any of these. And even if there is a capsule, it will have a pseudo capsule. Even if there is an infiltration, it will have a pseudo capsule and some minimal infiltration into the perinephric fat, but the outside surface will be entirely free. All the margins, the ureter margin, the vein margin, all these margins will be free. So this is most important for stage 1 and stage 2 also. Stage 2 also, it can have sinus fat invasion, it can have perinephric fat invasion, but the margins will be free. So in from pathology point of view, taking margins appropriately and looking at the sinus fat area, looking at the perinephric fat area, diligent sampling of that area to look for any residual tumor when you're seeing a lot of necrosis post chemotherapy, that becomes a challenge. So a lot of sections need to be done. And one important point about the renal vein margin is the tumor should be adherent to the wall of the margin to call it a positive renal vein margin. Sometimes the tumor thrombus is just protruding through the vein, it retracts outside if it is not sutured. So falsely, we can call it positive margin, whereas it would be just floating inside the lumen. So that is a very important section from a pathologist point of view, and the renal sinus fat also. And when we come to stage 3, if there is any lymph node involvement, like in COG, if there is any lymph node positivity, it upstages it to stage 3. In SIOP, we need to take multiple sections of the lymph node, because if there is even a response to therapy is seen, if we see any macrophages, any pigment-laden cells there, which are showing that there was some tumor, so that also upstages the tumor to stage 3. So if there is any tumor implant on peritoneal surface, if any margin is positive, a node is positive, or even if there is a response, it all upstages it to stage 3. And about the biopsy, we have discussed that if done from retroperitoneum, it now does not upstage the tumor. And stage 4 is a hematogenous spread. So if we, on pathology, if we get a sample from lung, if we call it positive, then it becomes stage 4, and bilateral Wilms make it stage 5. Thank
Yes.
you.
Thank you, ma'am. Sir, can we put the slide in slide shares? Sorry, slide screen mode so that it will be bigger in size.
Slide show.
Slide share.
Thank you.
Thank you, sir. Next slide, sir. So very important point from this case is the tumor thrombus management, because it has to be done in a say tertiary care center where there is good multidisciplinary systems are there to manage the child pre-operatively, operatively, and post-operatively. So as per umbrella protocol also, if there is short thrombus in the renal vein only, it can be resected, but it is a subhepatic thrombus, then already as Jindal sir has described that vena cavotomy and to remove the thrombus, and definitely during surgery we have to keep a view that it should not go to the opposite renal vein, and if the thrombus crosses the hepatic level, then the child will require cardiopulmonary bypass surgery. And definitely for staging, so staging is very important for to decide further chemotherapy after the surgery. And here comes the role of tumor margin, lymph nodes involvement, and histology of the tumor, that is the anaplasia or the blastomal predominant component is there or not. Next slide, sir. So we gave chemotherapy to this child. After chemotherapy, there was not much response. So we went ahead with the high risk SIO protocol, and after high risk SIO protocol, 4 cycles of chemotherapy, there was significant reduction of the tumor size and tumor thrombus. And as Basan sir already described, that we managed nephrectomy and the tumor thrombus removal, and completed the further chemotherapy protocol. Next slide, sir.
Um, so next we have a 4.5-year-old male child. They presented with incidentally detected abdominal mass since 10 days. On examination from head to toe, child also had apparent lower limb girth deformity, where the right lower limb was more hypertrophy than the left lower limb. And on abdominal examination, a mass was felt over the right side of the abdomen, which is hard in consistency, crossing the midline and reaching the left iliac fossa. And other systemic examination was normal, and there was no evidence of hypertension. So imaging was actually done outside. CT scan was done, which is also a large pelvic abdominal heterodense lesion, which is arising from the anterior cortex of the upper pole of the right kidney, showing liver metastasis. And the child was referred to our center for further evaluation. So at our center, we did a HRCT chest to look for any evidence of lung metastasis, and there were multiple subpleural nodules which are seen in the bilateral lung fields, and multiple variable sized round hypoattenuating space occupying lesions within the liver. So there was metastasis to the liver and the lung with a background of probable Wilms tumor. Next slide, please. So these are the imaging findings. On the right side of our
You need
screen.
one more click so that
Yeah, can you next slide, please?
one more click, sir. Yes.
Yeah. So basically, you can see this imaging showing on the right side first, a heterogeneously enhancing lesion in the liver, and you can see a mass in the suprarenal region, which is displacing the liver, extending across the pelvis, extending across the midline into the pelvis, and another similar lesion is also noted in the posterior cortex. So this star, which you can see, is actually showing the enhancing lesion in the liver. And now coming to the left side, so one more click, please. Next slide. Yeah, this on this side we can actually see the nodules in the both lungs. on the left side and on the right side, if you can see. These small nodules are suggestive of metastasis. And you can also see on the other side, hypodense focus, which is noted in the left kidney upper pole at the bottom where the white arrow is. So this lesion actually would need MRI for better characterization, but this is like a lesion which could be a nephrogenic rest or maybe even another Wilms tumor. But anyway, post this imaging, we had started on chemotherapy. Next slide, please.
So, Dr. Kashif, can you please explain the role of PET-CT for Wilms tumor staging?
So I tried to go through the present articles and the recommendations. I think the upcoming role is in response assessment post chemotherapy. Uh, there were few articles which mentioned PET-CT could have a role in response assessment post chemotherapy. I think that can be used for stage 5 and stage 4 at the initiation or the at the time of first diagnosis. If it is stage 5 or stage 4, then chemo was given, and then we are reassessing. Maybe PET-CT will be useful, especially where you have to decide for sure that in one kidney it has how much it has responded. Is partial nephrectomy going to be possible or not? And like, is nephron sparing surgery? So all these decisions to be made, and then whether the tumor thrombus was there and that can be removed or not, and whether the thrombus is a bland versus tumor thrombus. PET-CT can be really helpful in those cases. Apart from that, lung nodules, actually HRCT is still superior to PET-CT because less than 1 centimeter nodules will not show FDG avidity, and untrained person may actually miss less than 1 centimeter nodule because you have to be very careful for that. With respect to any molecules for PET-CT, I think as of now, most of the centers have employed only FDG PET, and many articles mention 70 to 80% tumors showing FDG, which means that 20% may not show FDG as well. That is why PET-CT is not widely recommended or used. And you most of the times, based on the age of the patient and the renal mass, the diagnosis of Wilms is almost certain and does not require PET-CT in for diagnosing for that. And metastatic workup, it may be helpful. uh, I don't see any guidelines. If there are any guidelines or in any of the guidelines mentioned, please let me know if you know of that. I could not find any standard guidelines saying that PET-CT must be done. MRI, actually, I feel more and more MRI use can be useful, especially if it is bilateral Wilms. The ADC values have been described. The ADC values will go down, like, I mean, the restriction will reduce, and those values from 1000 may become 400 in post treatment. This is described, and FDG avidity again may not be comparable very easily because it depends on glucose of the patient, it depends on the timing of the scan. So that is little difficult. SUVs will not be comparable. So therefore, still it is in the like translational phase, and I think practical use may be for tumor thrombus.
Okay. And what should be the treatment principles for metastatic Wilms tumor? Yamini ma'am. Okay, we can take the third case by the time.
Metastatic Wilms tumor, yeah, if I can answer it, maybe.
Yeah, I think my audio was, auto off. So, multidisciplinary care with integration of chemotherapy, surgery, and radiotherapy is probably the cornerstone of management in metastatic WIMS. Since most of us follow the PSYOP type of protocol, we would start with a neoadjuvant chemotherapy with vincristine, adriamycin, and actinomycin D for a period of 6 weeks, reassess, and take a decision regarding surgery. So the change from olden times to the recent advances is that in olden times for pulmonary metastasis, we used to give whole lung irradiation irrespective of the response to treatment. Now, with the recent results, at 6 weeks, if you have achieved a CR in the lung, either with chemotherapy or with surgical CR, then you are justified in not giving the toxicity of whole lung irradiation. So you can stop with the adjuvant chemotherapy alone. In most patients with pathological stage 3 post treatment, we give radiotherapy. What about extrapulmonary metastasis? So most of these patients require radiotherapy to all sites of disease, like liver metastasis, you give radiotherapy to the liver, or brain metastasis, you give treat brain RT. So radiotherapy should always be integrated at these sites in metastatic. So it's basically a multidisciplinary management that would give us a cure rate in metastatic PIMS. As against the older studies with NWTS, where the results were approximately 80% 4-year survival. Now with the recent the AREN studies, the 4-year survival has reached approximately 95% overall survival. So with multidisciplinary care, I think metastatic WIMS again is highly curable.
Yes, ma'am. And sir, what should be the surgical principles for the treatment of metastatic sites? Although ma'am has told that metastatic to me, what should be the detailed principles for liver or the different organ metastasis?
Many, if the metastases are operable, we go for a resections. Single solitary metastasis, definitely metastasiectomy has a role. It can be done thoracoscopically also, or it can be done open. For multiple metastases are there, especially like 2 or 3, we can give that, and also we can try within wedge resections of the lung node, mostly subplurally locations. But however, the more than multiple metastases are there, like 3 or 4, whereas diffuse metastases are there, like a, then in that cases, I think doing a multiple lung resections, like doing a lobectomy kind of thing. In that case, if single lobe is involved, we can try a lobectomy of that also, and the results are good. But multiple metastases, bilateral lungs are there, then in that case, I think, and there is no response to treatment after the initial ABD or even the XCCED. After that, there is no response. Then in that case, pulmonary irradiation is the options only.
Yes, sir. And to Jenny ma'am, that because there is syndromic association of Wilms tumor, as we have already discussed, basically with bilateral Wilms or nephrogenic crest. So, what should be the follow-up principles for these kids to prevent recurrence and of the same kidney and also the opposite kidney?
So, like in our this present patient, where we had hemihypertrophy noted. So the difference in length or size could be more than 1.5 to 2 centimeter. And when you see a patient with hemihypertrophy, you have to definitely think with treatment syndrome spectrum. It is considered a spectrum because the presentation could be with all the features of Beck, classic features of Beckwith Whitman, with neonatal hypoglycemia, macroglossia, omphalocele. It can range from those symptoms up to even they can present with only some subtle symptoms and signs, so just a hypertrophy, isolated hemihypertrophy, or even a patient with isolated Wilms with no features. If there's bilateral condition, Wilms, it's again an indication to test for Beckwith-Whitman syndrome, because bilateral Wilms in a child itself gives a clinical score for Beckwith-Whitman as 2. So any child with more than 2 score is supposed to to be evaluated for Beckwith-Whitman. So that is, we have to do an MS-MLPA. They look, this is an imprinting disorder. So there are many mechanisms causing this. So looking at various genes, their imprinting stage, and also uniparental disomy. So that will be the first line of investigation in any child with hemihypertrophy or an isolated Wilms. if they have, like we discussed earlier, they have any other syndromic features, the type of, I think somebody asked, the type of investigation also varies. So if you are thinking for with the WT1 associated with like this Dennis rash, placer, all now are considered a spectrum of WT1 disorders. So for that, we have to do the sequencing of the gene and gene targeted deletion duplication. If aniridia and associated WHER syndrome, then better to do a microarray where they will detect the deletions of the particular areas of the chromosome. And if there's other features like overgrowth syndrome, some of the overgrowth syndromes like SOTOS, so if they have those particular clinical features, then you do the sequencing. Nowadays, we do whole exome sequencing so that most of the related genes can be sequenced at the same time. So the type of testing will depend on the type of symptoms. Then for Beckwith-Wheatman, if in a neonatal period or infancy, if a child is diagnosed with Beckwith-Wheatman, then definitely the child needs follow-up with routine ultrasound abdomen. Till 4 years, the American Academy recommends every 3 months ultrasound abdomen looking at the liver, the kidneys. After 4 years, the risk of hepatoblastoma comes down. So we can do till needs every 3 months, mainly renal scan. And also AFP levels should be checked routinely in these children. And if you suspect neuroblastoma, again, ultrasound and PMA levels should be checked. And till 8 years is the recommended follow-up needed so that we can pick up these children before they actually present with a large Wilms tumor. So again, I think around 5 to 10% of Beckwith-Wheatman syndrome children will develop Wilms tumor. So the follow-up is definitely needed.
Yes, ma'am. So, to next slide, please, sir. To summarize this case, what we have discussed till now, that there may be upcoming role of PET-CT, but definitely till now HRCT chest is best modality to look out for lung metastasis. And also to manage the metastatic malignancy. The important point is after giving the chemotherapy, 3 drug for 6 weeks and response assessment, metastatectomy or according to the involvement lobectomy is important. And there is important point that now in few cases we can avoid radiotherapy, and one of that is if there is complete resolution, there is after chemotherapy, and if the lesion is persisting and after surgery metastatectomy the lesions are showing it's non-viable tumor, then we can avoid radiotherapy. Otherwise, in all the indications, involved site radiotherapy is required. And definitely follow-up schedules are very important to prevent a malignancy of the same site and also the other site. Next slide, ma'am. The next slide, sir. So for the follow-up, generally for first 2 years, 3 monthly follow-up with clinical checkup for the local examination and head-to-toe examination for other syndromic features, and imaging-wise, ultrasound abdomen or KUB of the local part and chest X-ray is very important. And for third and fourth year, third, fourth, and fifth year, every 6 monthly. Then, as ma'am told, that at least for 8 years of age, there is chance of malignancy. So till once a year management, once a year follow-up is required. Next slide. So here ends our question answer session. Now we have time, so we have 5 minute times. Most probably we can take few questions if left. Most probably all are already answered in the chat box.
How do you manage anti-hypertension?
Sorry. When we do nephrectomy, how do we manage those antihypertensives? Do we stop immediately or would we just follow up, in a graded manner?
Okay, so how long to continue antihypertensives?
Yes,
Yamini ma'am, you want to answer, ma'am?
Yeah, so most of the time we have seen that, antihypertensive post-surgery has to be continued at least for, 3 to 4 weeks. And then the hypertension resolves on itself, and then we can stop the antihypertensive. So usually, immediately you can't stop it. Most of them have some amount of hypertension. But after 3 to 4 weeks, the hypertension, antihypertensive drugs can be stopped. But if it's persisting, of course, we have to continue.
Yes. And there is one question. Jindal sir has asked that what is the role of diffusion weighted images sequence in identifying nephroblastomatosis? Dr. Kashif, please, can you answer, please? Dr. Kashif?
Yeah, so basically diffusion weighted imaging means the cellularity, that is the component that we are trying to assess. So even the nephroblastomatosis may show some amount of restricted diffusion, but it will not be just like a Wilms tumor. Wilms tumor will be more heterogeneous and nephroblastomatosis will be more homogeneous. And in Wilms tumor, you may see ADC values which may go up to 1,000 and all. So we can measure the ADC values, and there is something now coming up called as synthetic MRI. Now, what we are doing is we can, instead of saying T2 hyperintense, T1 isointense, now this is all a qualitative parameter. Now, something a quantitative parameter is coming up where the T2 relaxation time and T1 relaxation time is being used to measure the exact T2 and T1 of the tissue. I think in future we are going to do studies in across the world where they do T1, T2, like they calculate used on the mathematical equations and differentiate and tell that this is the T2 time T1 time for normal tissue, and this is the T2 T1 for abnormal tissue. So this is the thing that is going to come up in future. But as of now, the good modality which we have is DWI. In that, we will see heterogeneity and heterogeneous restriction in Wilms tumor. It will be more homogeneous in nephroblastomatosis.
Yeah, very only expecting the answer, and I want to highlight that key. Nowadays, MRI morely, even in hepatoblastoma, people they consider ki DWI images and sequences and ADC coefficient, which are more important to differentiate between this quality of the renal masses rather than the quantity, which is CT, we can differentiate basically. And even in with this DWI sequences also, there is 25% chance of we can misdiagnose that nephroblastomosis is.
Yes, sir. So that's why actually DWI is always done after a T2. So if we have T2 and DWI, that will increase the sensitivity and specificity. And upon that, if you add a contrast enhanced sequence, it is more than 99%, you will be able to differentiate most of the times.
Maybe. Thank you.
There is one more question to share experience of event-free survival and overall survival for Indian setting in bilateral Wilms tumor, with or irrespective of staging or surgery.
There is no large series to, I think, of a bilateral Wilms tumor from an Indian study. Some anecdotal conference presentations, no publications that I have seen. If anybody can share their experiences, that will be great.
Dr. Basan, can you please stop sharing the screen? We'll be able to see everyone.
Yeah,
I think the
I
INFOG
do.
data will be published soon, so we can have a look at the bilateral Wilms tumor. There are, I think, more than 400 cases in that. And what I remember is the overall survival was 89%, which was quite good. It's for across all stages, not for bilateral.
Yeah, we are in the
Yes.
process of publishing it.
Yes,
So
yes. So once it comes out, then everybody can see it.
Yeah.
They're expecting that. Let's see. Thank you, ma'am.
And in a Wilms tumor specimen, do we need to actively look for nephrogenic rest?
Ideally, we should look at, because the
Yes.
nephrogenic rest is a different burden, various spectrum of it can be isolated nephrogenic rest, it can be multiple nephrogenic rest, and it can be diffuse hyperplastic pre-Luba nephrogenic rest. And depending upon that, the risk of future development of Wilms tumors varies. And there is a various protocols has been described to observations, chemotherapy, as madam has told ki if diffuse hyperplastic nephroblastosis are there is a 100% risk that they are likely to develop a metachronous Wilms tumor also. So in that cases, they need to be very vigilant and chemotherapy has to be prolonged. And if a syndromic association is there, then again it again increases the risk further.
Yes, it changes the treatment, so it
Yeah.
should be looked for. Pulmonary metastasis assessment is looked after the neoadjuvant chemotherapy. This is the answer.
So I just want to say something about this pulmonary metastectomy. In the umbrella protocol, they lay a lot of stress on doing a pulmonary metastectomy at the time of nephrectomy, which many times is very challenging for us because of the small baby, large tumor, anesthetic challenge to operate on the abdomen as well as the lungs, and we are not routinely doing. I would like to ask all my other surgeon colleagues if we are routinely doing pulmonary metastectomy. But if you don't do pulmonary metastectomy and the metastases are persisting, then we have to upstage the chemo to the high risk protocol. And in case you need to give radiation, local radiation, and then you have to combine that, especially if you look at the right side, suppose you have to give local radiation because the flank radiation because lymph nodes are positive, and then you have to give pulmonary radiation as well, and they advise that we should give it at the same time to avoid toxicity to the liver. And our children in the Indian scenario do not tolerate this high risk chemo along with the lung as well as flank radiation. This is what my experience was, so I wanted to know what others feel.
Yeah, I agree, madam. This pulmonary metastectomy has a lot of controversy in Indian setup, especially. And what the umbrella or the SIO protocols has been described, we are not following the exact guidelines because of the logistic reasons. And ideally, it should be done at the time nephrectomy or maybe within a 1 week after the nephrectomy. So
Even
the
in TMA, we
NSS during the NSS basically or whatever. But if it permits, that's why the role of thoracoscopic metastectomy role is coming a big way, where there is a morbidity is very less.
We start actually radiotherapy by week 7.
1 week.
So, but our in Kerala we have a good nutritional status, and our children are much better than what we see, probably outside Kerala. Probably because of that, and I am in a center that is a private center, so
Maybe. If
As
So,
you
Dr.
ma'am, this
Jindal said, I think
radiotherapy is
staging
before
staging the
surgery.
metastectomy could be one option, after 10 days or something, because indication for pulmonary radiation is if it persists beyond 9 weeks. So we could still stage the metastectomy because,
staging metastaectomy is a very valid option, and even there is bilateral metastasis are there, we do stage
yeah,
metastaectomy only. We because bilateral thoracotomy doing is a
yeah.
very morbid surgery otherwise.
Yeah,
So
the other problem is getting one lung ventilation in a small child. That also is a challenge.
yeah, we in JIPMER had done 2 cases of pulmonary thoracoscopic metastasis, but those is solitary metastasis definitely. So we'll see the response. Not a long-term follow-up till now.
Okay. So we
Thank
have
you.
almost discussed all the cases and all the question answers also. So we are almost at the end of the session. Thank you everyone thank you the participants and esteemed faculties for sparing the time. And thank you Jyoti ma'am and Monica ma'am for giving me the opportunity to moderate this session. I hope this was helpful for all of us. Thank
Thank
you.
you.
thank you.
Thank you, everyone. Thank you.
Thank you, Dr. Somajipa, for doing this, moderating this session. And I missed Dr. Meenakshi and Dr. Shakeebuddin initially. I'm so sorry for that. But thank you, everyone. Thank you, Yamini ma'am, Dr. Meenakshi, and everyone who could join. Thank you.
Thank you so
Yeah,
much,
thank
ma'am.
you very
Thank you.
much. Yeah.
Thank
Thank you,
you.
ma'am. Thank you.
Thank you.
Monica, can you take a picture?
Thank you so much to all. Claret is really glad to have all these brilliant people together in this session today. Thank you so much for extending us the opportunity to host the session, and I hope you all had a seamless experience. So, with everyone's permission, I'm concluding the session in here for today. Looking forward to hosting you again. Thank you so much.